Okay, so it is time to get started. I can't believe it. 2 more days after this, all right, for us. So we've got the lecture quiz coming up this Friday, and then of course the final exam, which I sent out the exam breakdown. Please double check all your scores, especially with this right here, because I tried to be real careful for lab quiz, that's for L, lab, through the case study, which acts as an extra quiz. Please make sure that I've grayed out the right lowest score. So be my second set of eyes or many eyes, and just make sure I've grayed out your lowest score. And if I haven't, just correct me. All right. So I want to make sure and get that right. Because I've just got 2 more columns of data to add in. All right. And you guys know that at any point in this semester, you can always know exactly what you're doing in terms of a letter grade by adding up all the points. Don't add in your ID, adding up all the points you've earned so far, and then adding the possible points you could have gotten for those things, and then take what you earned under divided by what you could have possibly earned times 100%. And then of course you look up at the typical grading scale. All right. So when we get this last score in, you'll already know what your letter grade is because you just do the math and look up there, and there you go. All right. Okay. But I did want to remind you, please double check that I grade out the right scores, because it is a lot of numbers and there's a possibility, although slim, that I can make a mistake. So let me know. Any questions about that? Okay. What else? Okay. So we left off, and I don't know if we'll finish this chapter today. It'd be nice. Because Friday I intend on just you coming in, taking the quiz, and then maybe go cuddle with some puppies or kittens from between 12 and 3, because I found out they're bringing both of those. So anyway, work. There you go. Okay. So again, the importance of the reproductive physiology part of it for you guys, like I said before, is your patients, clients, patients, whatever. They might hesitate to even talk about these private issues. And so you should get really comfortable with this stuff as a nurse, because they're going to be looking at you as the professional and the person who knows. So if you project confidence in being at ease, they will then follow suit. If you act all like this, they're going to clam up. At least that's my experience. So we had talked about the different stages of egg development. And then the egg is like the car, and then the follicle surrounding the car, follicle surrounding the egg, is like the garage. When the car leaves the garage, when the egg is ovulated, there we go. All right. It leaves the garage stays put. So the follicle stays put in the ovary. And I think, because I wrote it down, we covered that follicle becomes the corpus luteum and makes progesterone. And I asked you, what does progesterone do? And no one knew. But it's the one that maintains, it develops the uterus for pregnancy and maintains it in that state. It's basically the hormone. The progesterone is the pregnancy hormone. And some women will have low progesterone and they might be at risk of a miscarriage, but you can always take supplemental synthetic progesterone. But those are things you might see. Now, I can't remember if there's something after this. I did want to define Mittelschmerz. Let's see here. Okay, so Mittelschmerz. Anyone know what that German word means? I learned about it when I was a teen because I had it. And I went to my family doctor and I said, oh my God, I've got a pain inside. It's probably cancer. I don't know what it is. And he described, and thank goodness I was tracking my monthly cycle. And he says, oh, it always happens around mid-cycle. You're feeling the pain of ovulation. That's Mittelschmerz. Mittelschmerz, let's see what my pen is doing today. Get a different pen color here. Is the pain with ovulation. Some women can feel it because it's a mini explosion. It really is. That Graafian follicle right here, full of fluid trapped in confined spaces, builds up tremendous pressure, enough pressure for the egg to be chucked out of the follicle and actually rupture a hole in the ovary wall. So it is a miniature explosion, and some women can feel it on one side or the other, depending on which ovary is ovulating an egg. If someone's trying to get pregnant and you have Mittelschmerz, you know exactly when you just ovulated, and you've got about maybe a 2-week window to get pregnant. All right, but that is a real thing, and it's fairly common. Now, it was later in the PowerPoint, but I copied and pasted it right after this, so it's not going to show up after this slide for you, but I brought it up. So under the influence of progesterone, Okay. No progesterone. I saw this on Facebook a while ago. Now I'm a TikTok addict, but back when I used to look at Facebook, I found this and I thought, wow, that really explains premenstrual syndrome for women and how they feel bloated. They feel, because without the effect of progesterone, this would be like week 1 to week 14 of the 28-day cycle. And then after day 14, which is when you ovulate, that corpus luteum is pumping out all that progesterone that starts to peak by day 20. Yeah, it's swollen, and not just in size from the exterior, but also in the interior. Because inside the uterus, and I'll talk about the layers of the uterus, there's a muscle layer that responds to things like oxytocin and what's the word I'm looking for? Prostaglandin. All right. Remember how I talked about the seminal vesicles in the male reproductive system? They produce an alkaline mucus. They produce fructose, a sugar for the sperm for their long journey. And then I said prostaglandin, right? And that causes the muscle layer of this uterus to contract, and it might help sperm get up to the fallopian tubes. Okay. So the uterus responds to hormones. The muscle layer responds to oxytocin or prostaglandin. And then the interior, if you were to cut this open, the inner layer of the uterus is called the endometrium. It responds to progesterone, because there's a lot of P words now to mix them up. And it will thicken, a good blood supply will be made there, and a lot of tissue will proliferate. It really gets thick. And so it swells basically from the inside out is what you're seeing here. But I like that picture. Okay. So we went over spermatogenesis, and we kind of went over oogenesis on the slide that has the picture of the ovary, the inside. And this is another way to look at it. Don't memorize this stuff right here, but I do want to call out the big difference in gamete production between reproductively mature men versus women. In women, you have all the little eggs, primitive eggs in the ovary when you're a fetus. You're born with them. At some point, all those little eggs, the oogonium, develop and they stay there. All right. Actually, basically from birth to puberty, at most that oogonium will enter into a duplicating set where it's called primary oocyte, where you get extra copies because these cells are going to go through division, or one of them is going to go through division. So up until puberty, this line represents puberty, pretty much these eggs are in stasis. They're stuck in prophase 1 of meiosis. Don't write that down, okay? But at puberty, under the influence of what pituitary hormone would stimulate that egg to go through and finish meiosis or maturation? You have two choices: pituitary hormones. FSH, follicle stimulating hormone, and the eggs are housed within a follicle, and that's where it comes from. It also causes sperm maturation. So basically, once puberty hits past this blue line, all right, monthly from puberty to menopause, when the woman's reproductive system shuts down, that primary oocyte, which is diploid, goes to a secondary oocyte. It's within that Graafian follicle that has all that fluid in it. All right. And at some point, usually mid 28 days, about day 14, that secondary oocyte, the car leaves the garage, the egg leaves the ovary. Okay. And the Graafian follicle, the garage, doesn't go anywhere, stays in the ovary and becomes this corpus luteum and produces progesterone for an additional 2 weeks after ovulation, 14 days. Okay. And so during this time, from day 15 to the end of the cycle, the uterus is proliferating like that image I showed you where the uterus gets really big. So that's what it looks like when the Graafian follicle ovulates an egg. Progesterone is released from that, maintains the uterus, and I call a pregnancy-friendly state. Now, at some point, that corpus luteum will die, and we'll talk about that because it's a complex cycle. But basically, progesterone from the corpus luteum is going to keep the uterus so that if a fertilized egg comes down from the fallopian tubes into the uterus and implants in that uterine wall, that progesterone keeps that uterine wall friendly for pregnancy and keeps that pregnancy going. And we'll talk about what happens if there's fertilization and if there isn't. Okay. Okay. Okay, review from the endocrine system. I don't feel like we have to go over this too much. So basically, you remember the hypothalamus, which is this right here. And this would be the anterior pituitary. This is the posterior pituitary where oxytocin and ADH comes out. But right here, all right, if it's reproductive, the hypothalamus secretes gonadotropin releasing hormone. The GN is for gonad. And that's going to tell the pituitary to secrete LH, luteinizing hormone, and FSH, follicle stimulating hormone. FSH stimulates either sperm or egg maturation. They go through their series of meiosis. LH stimulates the Leydig cells to make testosterone in the testes and estrogen production in the ovary. And I don't know what happened if I draw an arrow here. It might go to another slide. It won't let me do it because it's trying to hit those buttons. LH is what causes ovulation. At mid-cycle, day 14, you're going to have a surge of LH, and that's what causes the ovulation event. I don't know exactly how it happens, and then once the egg is ovulated, the corpus luteum forms. That's the garage that never left the ovary. That's the follicle, and produces the progesterone for about 2 weeks after ovulation. Now, learn this cycle because you're going to get teens or adults come in, and they're not even going to know about their menstrual cycle. I kid you not. It's true. They don't know the basics. Now, negative feedback. We covered this in the endocrine system. So the hypothalamus releases the GnRH, and then the anterior pituitary secretes LH and FSH. And down at the testes, LH causes testosterone production. FSH causes sperm maturation. If you remember at the beginning of the PowerPoint, I said the FSH is going to stimulate Sertoli cells to somehow help with sperm production. I don't even know how they do it. In the ovaries, LH causes estrogen production. And ovulation mid-cycle. And then FSH causes the egg maturation to occur. And it's not just the egg. I'm not putting it in here, but it is also the follicle matures along with the egg because the car's in the garage. Now, you know that levels of sex steroids, testosterone or estrogen, or even progesterone, if they increase high, right? Hypothalamus is monitoring that, right? So if T, E, or P gets high in the bloodstream, the hypothalamus senses it, and it will stop secreting the GnRH. The pituitary then stops the LH and FSH, and without the LH, I forgot the E on testosterone. Without the LH, those hormones stop production in their respective gonads, okay? That's the principle of negative feedback, right? If it's too high, the hypothalamus will shut it down, and that goes all the way down to shut it down to where those hormones are being produced. We know this now, okay? And yes, there will be no FSH. That means sperm and eggs won't mature because if you don't have FSH, you're not maturing these gametes. That's how hormonal birth control works. Okay, so you take a synthetic, and I'm going to add all of them, T, E, or P, or sometimes a combination of them, and blood levels increase, hypothalamus, I'll just put hypothal, decreases GnRH, and the pituitary decreases LH and FSH. That's negative feedback, right? So your hypothalamus can't tell the difference between a synthetic estrogen like estradiol, synthetic progesterone, progestin, and a synthetic testosterone, like the types you can find in anabolic steroids. Okay, so we talked about testosterone or synthetic testosterone and the dangers of that because it causes all these things to shut down. But if you take a synthetic estrogen, usually combined with progesterone, sometimes you can just take a progesterone like the depot shot. We're getting into birth control here. Hormonal birth control delivers synthetic levels of the estrogen and progesterone and shuts down this pathway. Because as the levels of the synthetic hormones rise in your blood, your hypothalamus can't tell the difference between the real thing your body makes and the thing that's coming in a pill, a patch, an injection, a NuvaRing, whatever. Okay, however you get those hormones in your body, the same thing happens. It shuts down GnRH, shuts down LH and FSH. Without FSH, you're not maturing an egg. Without LH, you're certainly not going to ovulate anything. So this is where, as a reproductive physiologist, I've seen a lot in my time. I've read a lot on the news and what very public figures say. And I actually heard someone who's newly elected to the Supreme Court like a few years ago say birth control causes abortions. And I'm like, what? Okay, as a biologist, I'm like, what did you say? Did you go to school? Even the basics of biology? No. But patients are going to come to you and they're going to be, they're going to have been absorbing some misinformation about how the body works and how pharmacological drugs work. And the birth control, like 90% plus of reproductive age women are on one form of birth control or another. It's important that you understand how it works because you're going to have to explain it to your patients. They're going to come in and they say, well, I heard this and I heard that. And like, no, that's not how it works. Let me explain it. And it's very easy to explain, just as easy as explained to you. Okay. So the reason I go over this stuff is because I know out in your future jobs, you're going to encounter this and you really need to be the voice of education and science and medicine and explain to your patients because they're coming in with all kinds of things they've heard and they need to kind of understand this stuff. All right. So I wanted to explain that really well for you. So I don't even think this is accurate. I think it's higher than that. Oral contraceptives. The birth control pill was the first hormonal contraceptive invented way back in the 60s, changed a lot of things. Okay. Usually estrogen combined with a progesterone, and that they found that's actually safer than just taking estrogen-based birth control. All right. So if you're taking the birth control pill, the typical, they've changed this a lot now, is basically 21 days of active hormonal pill. There's hormone in the pill. And then there's a sugar pill or placebo pill for 7 days in that pack. And they're marked differently somehow. All right. So that allows your body to be exposed to estrogen and progesterone enough to shut down hypothalamic GnRH and shut down pituitary LH and FSH for those 21 days. And then the 7 days of the placebo, you're not taking estrogen or progesterone anymore. The absence of the progesterone in your body causes the uterine lining to break down because without progesterone, all that tissue and blood vessels and all that stuff breaks down because you don't have progesterone. And that allows you to have your period. Okay. But there's different formulations of the pill, and I'm going off script because I don't have time this semester to cover it. They have seasonal. Anyone know about seasonal? It's where you take basically active hormonal pill for 3 months and then take a 7-day break where you have your period and then stay on active pill for another 3 months. See what I'm saying? So fall, spring, summer, and 4 seasons, basically. You have your period 4 days a year. There's even a version of the birth control pill where it's active pill year round. You never have a period. Okay. So if you don't know about it, learn about it. Can you think of any reason why? So when you're on hormonal contraception, taking active hormone in your body, the ovary is quiet. It shuts the ovary down. You're not maturing an egg. You're not ovulating an egg, and the ovary stays quiet. Can you think of any particular condition, a reproductive problem that women have that's common that would be a good reason for them to have fewer periods in a year? Anything? Maybe a disorder of the ovary? Polycystic ovarian syndrome, very common. What happens, remember polycystic kidney disease where the kidneys formed all these fluid-filled pockets, and it's the pressure of all those pockets is very painful and it can destroy kidney tissue. Same thing happens with polycystic ovarian syndrome. You saw that the follicles can fill with fluid. And in this polycystic ovarian syndrome, which is probably a genetic basis, multiple follicles will start filling with fluid, not necessarily maturing an egg, but just filling with fluid. And it's painful, okay? And it can damage the ovary. So if someone's diagnosed with polycystic ovarian syndrome, PCOS, this is a good reason to stay on hormonal birth control as much as possible. I would not, as a reproductive physiologist, say, just stay on hormonal birth control 365 days a year, because then you won't have a period. Fun, right? I don't know. I'm sure I could Google it if that comes at any kind of cost for a woman long term. Okay. But for some women, PCOS, the follicles filling with fluid are destroying the ovary, causing scar tissue and everything like that, and can permanently affect your fertility. Plus, it's painful. So as long as you stay on hormonal birth control, it's going to keep the ovary quiet. You're not going to have those follicles filling with fluid. And the ovary is not going to be inflamed and irritated and forming scar tissue or getting permanently damaged. Then when you want to have a kid, come off of it. And then when you're pregnant, during the 9 months of pregnancy, progesterone keeps your ovary quiet, and it's just working on that baby. And then after you have a baby, if you can, if it's safe to do with breastfeeding, go back on hormonal contraceptives again, protect your ovaries. All right. Is there any other situation where you might want to shut down the ovary, which will shut down its production of estrogen and progesterone? Another common condition that women have that's kind of painful. Endometriosis. Okay. And we'll talk about that. Okay. So I'm off script here, but I know about this stuff and I wanted to give you that information because you're going to be seeing people with PCOS, endometriosis, and they're the perfect candidate, other than women who just don't want to get pregnant, for hormonal birth control and long-term hormonal birth control. And what do we know about tissues that are chronically inflamed and form scar tissue, which can happen in PCOS or endometriosis left untreated? What can happen as a result of that chronic inflammation and scar tissue? Cancer. Those tissues are prone to a mitotic error known as cancer. So you want to have these conditions treated. Okay. Any questions on that? Because that was completely off script. I don't really have that stuff written down. Huh? Oh. All right. You guys kind of burnt out. You're just kind of like butts in the seat, just like trying to make it to Monday. It's okay. Faculty are too. Okay. Female reproductive stuff. Anatomy review. So your external genitalia is going to include the vulva, which includes the labia major, the outer, larger folds that grow the hair, and then the inner, smaller labia minor. And then, of course, the clitoris, which we now have learned that the clitoris is not just the little button that's anterior of the vaginal opening. It actually goes basically beneath the skin and is actually kind of a large structure. Google it sometime. Shape of the clitoris. It is actually pretty amazing. The clitoris is erectile tissue with sensory nerves similar to the head of the penis. They're analogs of each other. They're the same. When you're forming in the womb at around 8 weeks of age, before 8 weeks of age, you have basically a genital nub. All right. And if that thing is exposed to estrogen, it kind of forms into a clitoris when the baby's born. If that thing is exposed to testosterone, it will elongate into a phallic structure we know as a penis. All right. They start from the same tissue. They look the same prior to when hormones in a fetus's body affect it. So yes, the clitoris does arouse during sexual arousal and fill with blood, just like the corpus cavernosa of the penis. And it has about the same number of sensory nerve endings. Did I blow your minds? Did anyone know that? Okay. Well, now you do. Okay, internal structures that form when the fetus is in utero under the influence of estrogen. Of course, the vaginal canal, right here, not there, that's the urethra, which leads to the uterus. And then I got a lot under the uterus, which is right here, okay? The muscular sac is the uterus. It can support a developing fetus, and I'll get to the importance of that too. The uterus, if you took anatomy and looked at the textbooks, has a whole bunch of suspensory, there's a broad ligament that is really strong that helps support the uterus, because when a baby is growing in the uterus, it can be anywhere from 5 pounds to 10 or 11 pounds. All right. Think of a bowling ball inside your belly. All right. The supportive ligaments around the uterus are the only thing capable of standing up to that kind of weight in the uterus. And so the lining of the uterus right here, the white line, is this thing called the endometrium. It produces hormones. Okay. I'll put here, produces prostaglandin. It's an N. When there is no progesterone, and I'll get to that in a second. And I'll put under here uterine cramps. Oops, R. Okay, so that's this layer right here. All right, the endometrium is where an embryo implants. Okay, so that's a lot to do with the endometrium. Okay, so obviously the endometrium can respond to progesterone by thickening. And when there's no progesterone, that endometrium itself produces its own prostaglandin. Yes, seminal vesicles in the male reproductive system produce prostaglandin and seminal fluid, but the uterine layer itself, in the absence of progesterone at the end of your menstrual, or towards the end of your menstrual cycle, will produce prostaglandin, which is an inflammatory chemical that causes the uterine muscle to contract. So when there's no progesterone, the lining of the endometrium breaks down because there's no progesterone. It needs the progesterone to stay in that pregnancy-friendly state. But if there's no pregnancy, eventually the corpus luteum dies, progesterone production stops, and then the lining of the uterus breaks down. And gravity can cause some of that tissue and blood to come out of the uterus, out the vaginal canal as your menstrual flow. But the body wants to make sure that every bit of that tissue is ejected from the uterus, because if any of that tissue is remaining in the uterus, it could cause an infection, and that would be a problem. So the uterus, the endometrium produces prostaglandin, causes menstrual cramping. So whenever you have bad menstrual cramps in your period, you go, damn, you prostaglandin. But the prostaglandin is serving to evacuate all that tissue out of your uterus, so no tissue remains behind. That can be the source of an infection. So good side, get rid of all that tissue out of your body. Bad side, menstrual cramps can be a bitch, okay? Things like Midol and other drugs that are supposed to treat that actually basically work on inhibiting prostaglandin. But you got to be a little bit careful because you want to make sure your body gets rid of all that tissue. So this is nowhere on a script. So I'm just telling it to you just so that you know. Okay, the cervix is right here. It's the entryway from the vagina to the uterus, and its opening is no more than a few millimeters. And that's enough to allow menstrual fluid to come out after a menstrual cycle. People who have gone through a pregnancy, how wide must the cervix be before you're allowed to actively push to get the baby out? 10 centimeters. I don't have a ruler on me, but that's pretty big. Okay, enough for a baby to come out. So this is obviously is going to respond to pregnancy hormones and oxytocin. What does oxytocin do again? Causes uterine contraction. So the myometrium responds to oxytocin and prostaglandin, which the endometrium is producing when the corpus luteum dies. Okay, so prostaglandin produced by the uterus itself, the inner layer, causes the muscle layer, which is the pink stuff here, to contract, but only minor. Believe it or not, it's a minor contraction. Oxytocin causes this muscle layer to contract. A little bit of oxytocin causes a little bit of uterine contraction when one's breastfeeding. You remember that, right? Positive feedback. And the amount of oxytocin that's released during childbirth is gargantuan compared to when you're breastfeeding. And that causes the huge uterine contraction that can squeeze an entire baby out of your body. Now I'm making every woman in this auditorium go, oh, right? Yeah. Am I wrong? That's right. You got a C-section. And then attached to the uterus, if my torso is a uterus, my hands like this are fallopian tubes, are called uterine tubes. And at the end of the fallopian tube, all right, it's called fimbria, I think fingers, your ovary is right here. And the fallopian tubes don't connect directly to the ovary. There's a gap. So when a mature egg is ovulated in a mini explosion of ovulation, it gets chucked and hopefully it gets caught by the fallopian tube and then starts heading down where it might meet sperm or it might not. Every once in a while, the egg might miss the fallopian tube because of that space. And I'll talk about the significance of that in a little bit. Okay. And then of course the ovaries, which we certainly covered the egg maturation, ovulation, and everything like that. Okay, here's a view, get used to, okay, get comfortable with it. Because as nurses, you're going to be seeing that for all kinds of pelvic exams, urinary tract exams, all kinds of things. So external genitalia, the clitoris will be here. It's anterior to the urethral opening and certainly anterior to the vaginal opening. Of course, there's the anus opening. Do not make the mistake that nursing faculty have told me years back. When they get to the sim lab and they work with the interactive human model, if they have a man and a woman and children now, And they say, place a Foley catheter. Which of those holes is the Foley catheter going in? The urethra, okay? If a woman's coming in for a pap smear and you got to place the speculum, where's the speculum going? The vagina, okay? Because the pap smear is where you take a sterile swab and you swab the cervix, and there's only one way to get to the cervix, which is there. And if you're doing colonoscopy, you're involved in that, well, you're working there. Don't mix these openings up. Don't do that, okay? Know your anatomy. The labia, major and minor, okay? And then the vestibule is basically this pink tissue that surrounds, comes up to the clitoris, surrounds the urethra, and surrounds the vagina opening. And I put there, prone to tearing during childbirth. As that baby is crowning, and certainly when the shoulders come through, it can put enormous pressure on that tissue, which stretches to its maximum capacity. And every now and then, you're gonna, as a seasoned nurse, physician assistant, or whatever, you can tell when a tissue is going to tear. I've seen it during not childbirth, but animal birth on the farm. Okay. When that tissue is stretched and it turns white, it's kind of reached the end of what it can stretch and it's likely to tear. All right. Not a good thing to think about, but what will happen is if the doctor, whoever's helping with this birth, sees that happening, they might do a preemptive little cut to allow a little more expansion room to allow that baby to come out. You don't want uncontrolled tearing through the vestibule this way or this way. What if it tore up into the urethra? What if it tore downward into the anus? Now fecal coliform bacteria is everywhere. All right. Does anyone know the name of that procedure that's done? It might be on the slide. I forget. Let's see what next. Oh, there it is. Episiotomy is a controlled incision to prevent tearing during childbirth. There's an L in there. And that can certainly happen. All right. And then after the childbirth is done, you put some stitches in there. It might burn a little bit for a couple of weeks while that's healing, but they usually heal up 10 to 14 days. Hopefully no problems. If you have uncontrolled tearing, that won't be good. That likely is going to be a jagged tear. Who knows what it could tear into. So looking at the time, I do have some little clips. I didn't check that, make sure that the links were in fact working. They might be broken, but I hope not. So let's look at delivery. And they're not actual videos. I don't want to do that to you on a Wednesday morning. Okay. They're kind of diagrammatic. Okay. Make this big so you can see it. Oh. I didn't know there was going to be music. So the normal birth, let me turn it down a little bit. Where's volume? You can't tell the volume, so I'm not going to mess with it. But the normal presentation is, of course, head down and face towards the butt. That's the normal presentation. And the cervix is expanded. The vagina might evert a little bit. Don't worry, it should go back in. All right. And then the crowning of the head, and the shoulders are the next wide thing to come through. Oh, don't put that on the screen. I want to see this. All right. And then someone should be there to catch that baby because it looks like it's just floating off into space. Okay. All right. So that's a birth without any problems. Let me get the volume a little bit down here. It's a little kind of loud. There we go. Okay. So that's childbirth, uncomplicated childbirth. Okay. Let's go right to the episiotomy. It's funny that when I look at it, I was like, who's catching that baby? Come on, get on it. You know? Okay. Episiotomy. Again, it's not a real episiotomy. I wouldn't do that to you. All right. So here it is again. Okay. Yes, provided in this video for educational purposes only. Okay. So this is something that has to be done to prevent the uncontrolled tearing. Now I want this louder, so you don't have tearing.
During pregnancy, your baby grows inside your uterus or womb and is nourished by the placenta.
There's the placenta.
When your baby is ready to be born, later.
I just paused it. The placenta. because I don't have this in my PowerPoint. It's a filtering organ. It is. It filters mom's bloodstream. So all the goodies, nutrients, and oxygen comes through and diffuses from high to low, across the placenta, and then merges with the baby's circulatory system. And when the baby's got wastes, it comes out fetal veins, merges with the placenta, merges with mom's circulatory system, and she gets rid of them. So placenta, all right? Here we have the birth
During
again.
labor, your uterus squeezes or contracts to push your baby through the open cervix and into the vagina, which expands to allow your baby to pass through and be born. An episiotomy may be done in an effort to avoid spontaneous tearing during delivery if your baby is large or in the breech position. Labor is going too quickly.
You know what breech is, right? The baby's not head down. All right, feet are first. Now, it's not that it can't happen successfully. I've seen it in animals where the feet come first. As long as nothing's hung up, tangled in the umbilical cord, or butt first, that won't happen. All right, because it won't fit through the birth canal. So breech. Go back.
If instruments such as forceps or a vacuum extractor are needed to remove your baby from the birth canal. An episiotomy may be done to help speed up delivery if your labor is going too slowly, or if you or the baby are in distress. If you have not
They do numb
already
it first.
received anesthesia before your delivery, your doctor will inject medication to numb your vaginal opening and perineum, which is the area separating the vagina and anus.
All right, that's the perineum.
Using surgical scissors, your doctor will make a 1 to 3 inch midline
Or paramidline.
lateral incision in the perineum. A midline incision extends straight down from the vagina toward the anus. A mediolateral incision is made on an angle from the vagina in the direction of the anus. The benefit of the mediolateral incision is that it is less likely to tear through to the anus. The downside, however, is that it can also be more painful and take longer to heal. Once your doctor delivers your baby and the placenta, he or she will close the episiotomy incision with stitches. These stitches will be absorbed by your body and do not need to be removed. An episiotomy usually heals without complications, although it may take several weeks. Within the first 24 hours, your nurse will likely help you apply ice packs to the stitches.
Okay. All right. So let me stop that. Okay, so continuing on. Got a lot. Okay, epidural. If you've got an epidural going on and it's still active, they don't necessarily need to numb it, because the epidural functions to deliver basically a numbing agent so that you don't feel the birth. Okay, but there is a time limit on when you can get an epidural, and if it wears off in the delivery process, they're not going to do another one. So anyway, you have to choose your birth plan. Are you going to go without epidural or get the epidural? An epidural can be done also if someone's just got disc problems or pain, and it helps numb that area, but also it's done during pregnancy.
Epidural spinal injections are a form of steroidal injection used to treat pain in the spine, normally caused
Or
by nerve compression
for
due
childbirth.
to herniated disc, degenerative disc, or other spinal conditions. A small needle is first used to inject local anesthetic to the area.
Numb the skin and
The
area.
steroidal injection is then inserted into the epidural space above the
You don't want to
compressed
hit the
nerve.
nerves.
The aim of the treatment is to relieve the pressure on the nerve, reduce inflammation, and thus reduce pain.
So obviously they're talking about it in terms of, someone's got a disc problem, but that's the same process is used if you're giving an epidural to numb a wound basically below a certain point so they don't feel the childbirth happening. And of course, C-section. I should just have you come and explain it all because you've been through it. Oh, sorry about that. Can't do anything.
Two things are correct.
I can mute it.
Well, Liberty Mutual customizing your car.
You know why they call it LIMU, right? The emu, Liberty Mutual, ILIMU, LIMU. Huh? No?
An own uterus to deliver a baby. Some cesarean sections are planned. More often, however, the need for the procedure becomes apparent after the onset of labor, when abnormal conditions make a vaginal delivery unsafe for the mother or her baby. Common indications for cesarean section include dystocia, placenta
Difficulty giving birth.
previa, and fetal distress. Dystocia or
So dystocia is the term. Dys means abnormal, right? So that's a difficult birth. That's just a general term.
non-progressive labor can occur when the baby's head is unable to fit through the birth canal or its body is in an unfavorable position,
Like
such
breech.
as perpendicular to the birth canal or buttocks first, which is the breech position. Placenta previa occurs when a low-lying placenta partially or completely blocks the cervical opening.
So the placenta is in the way of the
Occurs
baby getting through.
whenever the health of the baby is
Or
in imminent danger,
umbilical cord around the
usually
baby's
from
neck.
inadequate blood flow through the placenta or umbilical cord. Fetal distress can occur when the placenta separates from the wall of the uterus prior to delivery or the umbilical cord becomes compressed or squeezed. Other conditions that may require a cesarean section include multiple
Yeah.
births, large tumors of the
Fibroids, we'll
uterus,
talk about that.
genital herpes or
Oh, that's a good one.
infections, or medical problems such as uncontrolled diabetes or.
Okay, so think about this. If someone's got genital herpes or AIDS, okay? The baby comes through the birth canal, especially genital herpes, all right? The baby comes through, is being squozed through the birth canal and is picking up all that viral load, and it can get it in its eyes and all over and get.
That's why they administer with the ricin in the eyes.
Please say it louder so everyone can hear it. Thank you.
So after baby's born, regardless if they're have an infection or not, they administer with the ricin in the eyes to make sure there's no infection.
Yep, because baby, if not that's not done, and they get virus in their eyes, and that virus could be there forever, and they have terrible eye problems. Yeah, just to be on the safe side, right? Yeah. Okay, so there's lots of reasons to do a C-section. If you ever see a woman who's giving birth and you see coming through the vaginal canal and everything, a greenish or brownish or even blackish material, that's fetal poop. It's called meconium, and that means the fetus is in distress, and that means C-section. All right, and they're monitoring the fetus as well as the mom. And if the fetus heart rate gets to a certain point or mom's blood pressure bottoms out, rush to surgery to do a C-section. All right, if the placenta prematurely sloughs off the uterus, that can happen. That means mom can start hemorrhaging and die. Right to the emergency room, right to surgery. Okay, you're gonna see all this stuff. Aren't you excited? No. Okay, I think it's exciting. I'm actually very envious of the journey that you're going to be going on. Okay, got a little bit more time here, so let's continue. Get off the stuff that's possibly scaring you. Okay, so the uterus, the endometrium is, of course, the inner layer right there that responds to no, that's not. It produces it produces prostaglandin. But it also responds to progesterone coming from the corpus luteum, and it can thicken in your menstrual cycle. The myometrium is the red layer. That's responding to prostaglandin by contracting. It's also responding to oxytocin by contracting. And then the outer lining, I don't have much to say, it's just called the perimetrium. All right, you'd have to cut through that in a C-section. Now, this is where I had this originally in the slide, so I don't need to go over it. So endometriosis. That inner lining, the endometrium, that's why it's called endometriosis, migrates out of place. And they don't know exactly why, but it can migrate. And since the fallopian tube and the ovary don't have a direct connection, if that endometrial tissue migrates up the fallopian tube, it can actually lodge itself in the fallopian tube. It can lodge itself on the ovary. It can actually lodge itself on intestinal, liver, stomach, pancreas. It lodge itself on different organs in the abdomen because that endometrial tissue escapes from the fallopian tube and migrates elsewhere. Now, every time a woman has her menstrual cycle and the corpus luteum is producing progesterone, all those patches of endometrial tissue thicken and enlarge, and it can cause extreme pain. The fallopian tube it's not very thick, not very large, and that can even block the fallopian tube entirely. So endometriosis is painful, and it can cause permanent scarring of the reproductive tract, limiting a woman's fertility. This is a patient who hormonal birth control, they're a good candidate for it. Also, and I won't get to this today, we'll get to it on Monday, the amount of progesterone and estrogen in a woman's body during her menstrual cycle fluctuates. Sometimes it peaks, sometimes it drops. Progesterone can peak get really high and then drop. So it's very variable. The hormones in birth control are pretty rock steady. So the uterus itself won't thicken as much because of the rock steady progesterone levels. So people with endometriosis, they don't have their uterus thicken as much and their periods might be later. And that means other patches of tissue won't thicken and cause so much pain. So that's how that works there. But you're going to see endometriosis. How about we end on uterine fibroids? Uterine fibroids are leiomyomas, what they're called, leiomyomas. Some lyo, I've heard leiomyoma. It's just this non-cancerous tissue that can grow in your uterus. It can grow in the cervix, that's very painful. It can grow in the muscle tissue of the uterus, or can actually grow inside the uterus itself. They're usually non-cancerous, but when they get big, they can cause pain. If you're trying to get pregnant, it could possibly interfere with that. And they do grow in women as they age. So if they get to the point where they're painful, inhibit fertility, or any other things, you can remove them. Here's a fibroid that's actually filling the body of the uterus. That woman would not be able to get pregnant. All right. And you can cut them out surgically or through laparoscopic surgery. But a person who's prone to getting them is prone to getting them again and again and again. So if a woman's at the end of, she's had all the kids she wants to have, and she's having problems with uterine fibroids, it might be best if she actually get a hysterectomy, which removal of the uterus removes the problem. All right. Okay. So we'll finish this chapter on Monday. On Friday, it's just the quiz, and then you go.